about the post-pancreatectomy hemorrhage and to devise an algorithm for management. All of us scientists and all of us deal with pancreas day in, day out, and all of us understand the complexities and the basics of pancreatic surgery and the hemorrhages. There are so many factors which can lead to and guide towards management that developing an algorithm is not going to be an easy task. Also, I very strongly believe that when we develop guidelines and algorithms these days, in this era, where there is a lot of infiltration of technology, AI and machine learning, the algorithms are going to change, and very soon in the near future. And therefore, my presentation is probably going to give you a further insight into why algorithms are difficult to develop and what's probably the future algorithm going to look like, and what's the future generation going to depend upon when it comes to management strategies and algorithms clinical use of these algorithms. So my first few slides are going to tell you the background of post-pancreatectomy hemorrhage, what are the innumerable variables which can affect the hemorrhage, what are the management options. There are also numerable options, and therefore what should finally I'll try to take you through what I try to develop through some bit of AI estimate as to what a future algorithm should look like. So these are the classifications. Earliest was 2007, wherein it was divided into grade A, B, C. I'm not going to the details. C is, of course, the most severe hemorrhage requiring intervention and has a definite mortality factor there. But the recent classification has also given a time-based and a location-based, like intraluminal, early or late, and of course the severity, which incorporates the hemodynamic effect. The current trends, just to give you a background of the problem, 5 to 16% of post-pancreatectomy hemorrhage, I'll call it PPH. Please don't get confused with postpartum hemorrhage. I'm talking about post-pancreatectomy hemorrhage. So it's early is about 2 to 8%, and late is about 3 to 12%. Highest is with total pancreatectomy, and I'm sure all of us would have had that experience with us. With grade C hemorrhage, the mortality goes up to 15 to 25%, and at least about 40% have been shown to be associated with POPF. And therefore, what's happening is, if you try to go through the research in the last 15 years, as far as the post-pancreatectomy hemorrhage is concerned, most of the papers are analyzing the database studies, larger databases, and impact of standardized protocols on outcomes. And there are, of course, regional variations, and centers are trying to modify their own strategies to decrease the PPH and improve the outcomes once the PPH occurs. Not going to the details of the pathophysiology and anatomical considerations, we understand that what all can cause and where all the pancreatic hemorrhage, post-pancreatectomy hemorrhage can come from. But important risk factors have been identified, and they are stratified as follows. So there are certain high-risk factors, and the odds ratio of more than 3, which includes previous abdominal surgery with adhesions, chronic pancreatitis with calcification, neoadjuvant therapy effects, advancing age, and cardiovascular comorbidities. So it is interesting to note that neoadjuvant therapy, while it reduces the POPF rates, it increases the rate of PPH. And moderate risk factors include the diabetes mellitus, the obesity, preoperative biliary drainage, and of course the low preoperative albumin. Apart from that, as we all understand, soft pancreas predisposes to it, small pancreas duct predisposes to it, vascular reconstructions, operative time of more than 6 hours, and if the blood loss is more than 500 ml during the operation, it also predisposes to it. Surgeon volume, of course, makes a difference. More than 50 cases per year reduces the incidence of PPH in a surgeon's hand, but at the same time, if you have multiple surgeons in the same hospital, the hospital volume also makes a difference. So if the cumulative hospital volume is also less than 50 cases a year, probably the incidence of PPH is higher. And of course, there are validation scores which are being developed, and one of these validation score has been developed by Johns Hopkins. Clinical presentations, I'm not going to the details, but you can have early and late. And laboratory markers, hemoglobin trajectory analysis, coagulation parameters, etc. can be done. And of course, ERAS protocols, wherever instituted, may have some effect on not the technical, but the late PPH, as they say. Now coming to the management strategies, and that's where the algorithm confusion comes in, because you have so many variables which can cause PPH, you now have so many modalities which can control PPH. One can manage it, I mean, of course, when it comes to imaging and identifying the source of bleed, one has to use CT angiography, and the diagnostic accuracy is about 90 to 98%. Conventional angiography for embolization and stenting and various other ways of arresting that bleed, which is ongoing. But at the point of source, ultrasound applications, bedside assessment capabilities, Doppler evaluation capabilities, and of course, now there are clinical presentation-based pathways which have to be encountered, which have to be incorporated into the algorithmic approach. So, choices are to manage these patients conservatively, or endoscopically, or through the interventional radiology, or of course surgically. Now, just try to look at this. These are the conservative options. Blood products, coagulopathy, fluid resuscitation. Endoscopic options, what anastomosis, where can the endoscope go, how it can treat. Rebleeding rates are 15 to 25%. There are selection criteria. These are the interventional radiology options, and these are the surgical options. Now imagine with these kind of variables, so many variables, so many treatment options, how can one develop an algorithm? This algorithm, in the conventional way, the way we look at it in textbooks and articles, if we try to develop such an algorithm for PPH as a whole, I think it will run into pages, maybe 200, 300, 400 pages, because, and particularly now with the research which is going deep into the science, this is going to be getting much more complex. And therefore, when it comes to multidisciplinary decision-making framework, it's not about PPH, it's about every disease, it's about every complication, it's about every phenomena, every occurrence. We need to have algorithms, but those have to be interactive algorithms. In the future, with the future generations, with lack of patience, I would not say lack of patience, but lack of patience in the presence of available technology, which is very robust and getting better day by day, I don't think one will have to go into those details of textbook algorithms. I'll show you the examples of interactive algorithms. This was the paper, this was published only 2000. This is just this year, data from more than 1,000 patients from a Japanese center, diagnosis and management of post-pancreatectomy hemorrhage, and just try to look at this algorithm which they have mentioned. Out of all the patients, 33 patients had the bleed. The only thing that you can make out is that how many patients were subjected to endoscopy, how many got better with endoscopy, how many were subjected to surgery eventually after that, and it's a very simple algorithmic approach. And if you look at this, this is the ISGPS grading. Even if you look at this A, B, and C, you will find words like patient's clinical situation well, often well, severely impaired. These are very, very subjective, very different, and therefore may not apply in the clinical practice. If you try to look at the various sites of bleed, these are just the technical or the arterial sites of bleed. After PPPD, after distal pancreatectomy, after central pancreatectomy, and location of the bleed, whether it was intraluminal or the extraluminal. This data was published in a meta-analysis in 2019, and common hepatic artery, splenic artery, etc., etc. Once again, trying to emphasize upon the fact that if we try to consider so many variables, it becomes difficult for the reader or the person who's trying to do we have the preview room? Can you please press on this link? Yeah, I tried, it was working in the preview room. I put it up in the slideshow and try to work on this link. Okay. Okay, so you might have to come out and work on. So this is what the future algorithms are going to look like actually, wherein all the data will be pooled from all the organizations, federations, societies, etc. Like for example, this is a late post-pancreatectomy hemorrhage. You put your patient information there, you put the current presentation there. It is going to ask you for various vital signs and the additional information that you have, and it will also give you 4 choices. And I mean, that's just an example that I created out of, I have a little interest in digital AI, etc. So these are small examples that I created. And so if I say, what is your immediate management policy in such a situation, and I say immediate surgical expiration, then it is going to give me an answer that this is not the optimal choice. It is not correct in hemodynamically unstable patients with suspected PPH. Urgent CTA is the gold standard, and this is also going to give you an evidence that IHPBA 2023 guidelines recommend CTA as the first line imaging. Similarly, if I go to say conservative management with monitoring, it is again going to tell me it is not the optimal choice, conservative is not the choice. But if I say urgent CT angiography, it might say clinical reasoning correct and something like that. So these are the ways the future algorithms are going to develop, and then if you ask them the next step, it's going to give you the next step also. Can you go to the next link, other link please? So, and if somebody is trying to review from the academic or the research standpoint, or if it is a student, or if it is a new pancreatic surgeon, and particularly concerned about, or he has just had a PPH, he might actually go and see what are the early recognition. And early recognition, it will tell you the data that early recognition reduces the mortality by 40%, risk stratification guides care, like odds ratio of 5.6. Multidisciplinary approach is optimal in all of these patients, but it gives you data and and it is going to get further reformed, and it will give you actually the reason for what is important and why it is important. And here it tells you that with the kind of data that you submitted, urgent intervention within 2 hours is important to save or make a huge difference to the patient's life. And of course, angioembolization. So if you put in data based on the current evidence and the guidelines, which are of course developed by the researchers and specialists all across the world, all of this is fed into this AI engine. It is going to give you what is going to be the optimally the next step and where you might actually be going wrong. It's not that you have to depend entirely on such algorithms. Of course, the clinical condition of the patient and your clinical acumen comes into play and will remain the foremost. But sometimes, if you are confused between 2 or 3 modalities, it might give you an answer. Can you just show, my time is over, can you just press on just another last link, algorithm link? Algorithm, yeah, yeah, no, the next one. Yeah. So this is like an algorithm, because the time is up, I'll show you the full path. So this is, I tried to develop, it did not take too much of time. So you begin assessment of the patient with this, and if it is the stable patient, you fill in the data, unstable patient, you fill in the data. It tells you what are going to be the results like, and what are going to be the future, like emergency protocol, urgent CTA. It will guide you to the next step. It is known as an interactive algorithm, and this is perhaps going to be the future, as I said, for anything which is complicated and has hundreds of variables which can affect the outcome and the various decision making. Thank you very much.